The indication of growth hormone in childhood, there is a guidelines. There is American guidelines and there is European guidelines. In European guidelines, the indication for growth hormone therapy, number one, growth hormone deficiency, either acquired or congenital or idiopathic. Second, Turner syndrome. Third, small for gestational age who never catch up after 2 years of age. Renal failure and Prader-Willi syndrome and Turner syndrome and shocks. What I mean by shocks? Short stature due to homebox containing gene deletion. This is a common and must be confirmed by genetic study. That is the indication in European, as I mentioned. And in American, they add Noonan syndrome and idiopathic short stature. And another indication, but this is the indication that confirmed by European Society and for FDA in American. Growth hormone deficiency, Turner syndrome, Prader-Willi syndrome, and renal, small for gestational age, and shocks. Added to that, Noonan syndrome and idiopathic short stature in USA guidelines. Yes, about growth hormone therapy, from the studies and from our experience, it is safe till now, and there is no things just according as adverse chronic or neoplastic complication. But there is, in the beginning of starting using growth hormone, there is transient adverse reaction at the site of injection, like lipohypertrophy or sometimes edema of the feet, and sometimes muscular pain. And the most important in this respect is when the patient is returned back with severe headache. It is very seriously, and we must take that in our count. The growth hormone may increase the intracranial pressure, and so what we call the pseudocerebry. If the patient suffers from this, we must take in consideration and stop growth hormone, and then after disappearing this phenomena, we can restart the growth hormone in lower dose and continue. The other things, if the patient with the growth hormone is complaining of limping, this is what means for subfemoral epiphysis. It is also an urgent complication and maybe need to stop the growth hormone temporarily, and then, as I mentioned, we can back again. Otherwise, there is no such chronic complication or fear from neoplastic and so on. Yes, small for gestational age. We know small for gestational age is an indication for growth hormone therapy, but this is not from the first day or like this. Why? Because the growth, as we know, all of the pediatrician growth in intrauterine is depend on insulin. And from in the 2 years, it depends on thyroxine and nutrition and other causes. So growth hormone is not have place at this time. But at this time, we must monitor and follow up the small for gestational child by recording the height, the weight, the hair circumference 3 months, every 3 months in the first year, and then 6 months after second year. If the child at 2 years, he or she not catch up the normal growth, we must search for another cause, maybe nutritional, maybe other causes. After 2 to 4 years, if the child is still not catch the growth the growth, normal growth, we started growth hormone therapy. And the growth hormone therapy, the dose in this child is depend on the severity, and in FDA reached up to 0.67 microgram per kg. Yes, in developing guidelines for referral growth, this depends on, we have 3 parameters for the growth assessment. Number 1, the height standard deviation scores. Does it mean the height of the child, how it deviated from the mean? And there is what we call the target height standard deviation score, depend on the corrected height according to the parents of the family. And this can done by calculating the father height plus the mother height plus 13 for the boy and divided by 2. This is the mid-perinatal height. And for the female, father height minus 13 plus the mother height divided by 2. This is for the female. And the third standard is the delta height flexion, or the height velocity between two events, and preferably 2 years. This is the parameter for assessment of growth. And this can be done by taking a group of patients, for example, for 4 groups, short, and apply these parameters. With these 4, we have 3 normal population according to the age. For example, from 0 to 3, from 3 to 10 and above. And compare how many the percentage of referral according to this criteria. The criteria must be, for referral, must be high specificity and high sensitivity. So by this, we can develop a guidelines for referral, referral criteria. Yes, we have many guidelines. Especially, we have the Finnish guidelines and the United COM, and also the Dutch consensus guidelines. All the guidelines are depend on the consensus, not as experiment or studies. So in these guidelines, for example, in Dutch consensus guidelines, focus on the 3 I mentioned of surgical referral criteria mentioned above: high standard and the change in the standard with deflection and the delta. But when applied in this guideline, there is high percentage of referral, up to 30, more than 30 of the patient, and the detected pathology was not exceed 5%. So there is high referral of cases, and that is overburden the health system by investigation, by other things. So in this guideline, added to that, in this guideline, there is no guideline above 10 years. And below 3 years, it's also so difficult to catch a small for gestational age and so on. So we need to change base evidence guidelines that characterized by referral for high specificity and sensitivity. That is mean more pathological cases rather than we refer a cases that is need to follow or to go to approach diagnosis. And this may include, celiac disease is very important to exclude, and systemic disease, all the systemic disease, especially the systemic disease, what we call, that is lead me to explain what are the causes of short stature. The cause of short stature, 50% are physiological, either familial or constitutional delay. The second is systemic cause, more systemic causes, including any systemic disease, cardiac, renal, and so on. But must pay attention to the hidden disease, what we call bowel syndrome or bowel inflammatory disease that is not apparent, and celiac disease, not apparent, but the patient complain of short stature. And also renal, sometimes renal failure or renal complication presented with short stature. We must pay attention to that. Added to that, endocrine causes later, and then chromosomal as Turner syndrome, and then small for gestational age, and social deprivation. So it is very important to take this in consideration when applied to referral criteria. Now imagine I am received a patient referred to me with short stature. What the steps shall I proceed in diagnosis? Number one, the history. The history is very important for these cases. The history started since birth weight, hair circumference, and so on, and family history, and other diseases, system review, and so on. After the family history, the second step, the physical examination. The physical examination is very important, and many cases of short stature, one maybe get a clue for diagnosis from the history and from the physical examination. The physical examination also include the measurement of parameter of the height, the weight, and also the sitting height, over the ratio sitting height to the height, and if there is any dysmorphic feature, and so on. If I can't reach a clue in diagnosis in the history and physical examination, I go to the investigation. There is a simple way, and I am so happy in it, to reach the diagnosis or to follow up. Now, a short stature, I take the height and the weight. If the height and the weight, if the impact on the weight more than the height, this is mean what? This is mean systemic cause. Because in systemic cause, the impact is on the weight rather than the height. So I think of celiac disease and other causes. If the height is more affected than the weight, it is with endocrine causes. Growth hormone deficiency, hypothyroidism, and Cushing disease. If there is dysmorphic feature, this is go with chromosomal, either Turner syndrome, Down syndrome, and Noonan syndrome. If there is disproportionate, this is with achondroplasia and other bone dysplasia. If the height and the weight is normal, this is with physiological short stature, either familial or constitutional delay of. And this is the way, and according to that, I can proceed in my investigation. And like thyroid function test, growth hormone deficiency, celiac, and according to the guidelines I mentioned above. And also, we must judge the pubertal stage of this patient as MRI, bone age, MRI sometimes needed in growth hormone deficiency, and so on. When we complete this investigation, I can reach a diagnosis and continue in the therapy. Yes, thank you for this important question. And this is updated question. Okay. Genetic test is advanced now in the last decade, and there is a good advance in this respect. And more than 400 loci are discovered responsible for the growth, especially in the growth plate and in the pituitary growth hormone axis, IGF and axis. More than 400 loci responsible for the stature. So any deletion in these 400 maybe lead to disturbance in the growth, either short stature or other things. So in the future vision, our future vision, and I presented before 2 years in Dubai, the future vision for for diagnosis and management of short stature was genetic therapy and genetic diagnosis. How we apply this? How we apply this advance or new? How can we use it openly to all the cases, or there is some limitation, as especially the genetic test is not available in all the. For example, in our Middle East, there is no genetic study, and is available very limited in the world. So must be there is a scientific application for this study. Added to that, it is so costly, and especially in our region and in our condition now. Yes, there was a consensus that genetic or epigenetic test is not required for all short stature cases. Should be utilized in the diagnostic approach of specific groups of children whose phenotype suggests a high index suspicion of genetic causes. Severe familial forms of isolated growth hormone deficiency or a specific syndrome with multiple pituitary hormone deficiency. This is one indication for severe short stature below more than 3/4 population, and 3 body disproportion and or skeletal dysplasia. Especially in these cases, now in this respect, many cases in this proportion was discovered as shocks, and shocks is indication for growth hormone therapy. While now in our current, there is no indication for bone dysplasia as controllable age and so on. Small for gestational age who don't present adequate catch-up after 2 years. Patient with syndromatic short stature with syndrome. This is a clue for genetic study. A genetic cause of more likely to be identified where there is familial segregation with an autosomal or recessive pattern or history of sanguinity. There is another indication if we have a case and clinically we suspected it is a Turner syndrome. When I sent for karyotype, return back with 46XX. So this is indication for genetic study. And there is an indication to make a scoring how the clinician refer the cases to genetic study, and this is in the future, including the physical examination, the clinical presentation, the lab, the laboratory findings, and this is scoring completed and help to the clinician to direct it to genetic study or not. Education must be a part of our life. Previously and still now, the families must adhere to the maternal and health services. The maternal and health services include the follow-up of the growth of the child or the infant, added to that immunization. If the families and the healthcare is adhere to this program, surely will the child or the baby will discover easily as early when the GP or the family doctors follow the growth of this child, and he or she will address the problem and interfere either himself or refer to another doctor or specialized doctor. So adherence to the primary health services, especially the maternal and health childhood, is very significant in follow up the patient growth and to interfere when there is something. Added to that, in the school, in health school services, and must be the doctor, and must be the doctor is focused on the growth parameters, and especially when enters to the primary school. So it is very important for the doctors, for the family, for the healthcare to stick these services. And as I mentioned, the guidelines of UK was depend on the single height measure when the child entered the primary school for the first time. This is, as I know, in the UK guidelines. Yes, I can share. And during the COVID-19 or pandemic, there is a change in our life. There is lockdown, there is curfew, and so on. So the change is completely 100%. Previously, we sleep in the night and awake in the daytime because there is a school, there is other things join in the offices. But during this pandemic, this has changed. The child and all the family, they are stay awake during the night, and in the day they sleep. And we know the growth hormone is functioning during deep sleep in the night. So why we give growth hormone in the night when the child is asleep, and we ask our patient to take the growth hormone during the sleep and sleep in the night. Why? Because it is mimic the function of pituitary. The pituitary is pulsatile secretion of growth hormone during deep sleep. But if this change, this lead to a poor response to our patient, and there is no study in such respect, but it is a significant point must be taken in consideration. The other point about this is not related to pandemic. I remember before 3 or 4 years, a patient was referred to me for a prescription of growth hormone. The patient was underweight operation for craniopharyngioma partial in Bahrain or like this country, and she is from Iraq, from Baghdad. When I assessed the patient, the child or the patient, I sent for MRI, brain MRI, to check the pituitary and the craniopharyngioma, and this is documented. There is still part of craniopharyngioma. I refused to prescribe growth hormone for this patient, and I told her maybe there is an increase in intracranial pressure and the patient may be complication or loss of the vision. The patient didn't satisfy, and she traveled to outside Iraq, and another colleague from another country prescribed growth hormone, and the patient will receive the first dose of growth hormone. She collapsed and loss of consciousness and admitted to intensive care unit because increased her intracranial pressure. And the mother, she told me, I remember what I said. This is a good scenario to our colleague to pay attention that growth hormone may increase intracranial pressure and may, especially if there is a tumor or like this, to never prescribe growth hormone because there is complication. And this is a very interesting case. I never forget this scenario. Yes, in this year, I greatly all to this struggle against COVID-19 and continue to pay attention and to surface to our patients, in spite of many our colleagues are passed and our colleagues are still now with suffering from many challenges, either economic or some social problems. but in spite of this all challenges, they continue to pay and to service our patient. Really, it is a good and it is a very, very interesting work. Need congratulations for us, and myself, I one of them, and you also one of them, and to all my colleagues in the world. In evaluation a child with short stature, sometimes we depend on the perinatal heights and compare this with the child. We said this is familial short stature because his or her father and mother are short. But we must remember that maybe the father and the mother are short stature due to growth hormone, but at that time there is no growth hormone therapy. But this is very important. I have cases in this regard when I please send for X-ray for bone age. If it is delayed, this is with the growth hormone deficiency, and select the patient. And I have many cases in this respect. They never depend on this is familial because the father and the mother are short. Because the father and the mother at that time there is no growth hormone and they never receive growth hormone. This is very important to be remembered and because maybe miss cases of growth hormone due to this assessment. Thank you.